Good evening, everyone. Welcome to the Cardiac Electrophysiology session of International Young Academy of Cardiology E-Congress 2020. If you want to talk about cardiology, you must talk about ECGs. Today, we are going to discuss interpretation of ECGs in different scenarios. I am Dr. Haseeb Raza, and I am working as clinical cardiologist and cardiac electrophysiologist at Multan Institute of Cardiology, Pakistan. Along with my dear, Along with me, my dear colleague Dr. Emin will be with us, and I am going to chair this session and introduce you to our distinguished speakers. So, Dr. Emin, can you please introduce yourself to our audience?
Hello, everyone. My name is Emin Evren Özcan. I'm also an electrophysiologist from İzmir, Turkey, 9 Eylül University. I hope everyone will enjoy this session related with the different topics on different scenarios. We don't have too much time. It's better to start right now, I guess. Raza?
Yeah, so I'm going to introduce to our first distinguished speaker. Our first presenter is Dr. Hani Sabbour, and he is cardiac electrophysiologist at the Cleveland Clinic, Abu Dhabi. Dr. Hani, over to you.
Good morning. This is Hani Sabbour. I'm proud to be invited to the International Young Academy of Cardiology to be part of the session on arrhythmias. The title of this lecture is When is A.Fib not A.Fib? Rhythm Control Management Strategies in A.Fib in symptomatic young patients with a focus on SVT and WPW for early ablation. I'm Hani Sabbour. I'm a consultant electrophysiologist working in Abu Dhabi at Cleveland Clinic and an assistant professor of cardiology at Brown University in the United States. The learning objectives to identify arrhythmias that mimic A.Fib on ECG and unusual presentations, identify lone A.Fib patients who develop A.Fib, paroxysmal A.Fib in young patients, the role of ablation therapy and why it's important to refer early for WPW, disorders associated with A.Fib that do not have the same left atrial substrate, identify Brugada syndrome as a cause of lone A.Fib, and the role of sleep apnea as a major trigger for atrial fibrillation. Diagnosis of A.Fib, the basics. All patients evaluated for A.Fib should have a detailed history and physical examination to look for the risk factors, particularly CHAD score, and also to look for the triggers. There are characteristic ECG findings in A.Fib: absence of P waves, irregularly irregular RR interval, generally a narrow complex tachycardia with rates up to 160 beats per minute. QRS duration is usually narrow unless pre-existing bundle branch block, aberrant conduction, or an accessory pathway. Note that fibrillatory waves may mimic P waves, and remember Ashman's phenomenon. QRS morphology can be due to aberrant conduction, abrupt change of the cycle length, and usually these aberrantly conducted beats have a right bundle morphology. In addition, your evaluation should include workup for specific causes: electrolyte, endocrine, especially hyperthyroidism, drugs, infections, drugs or chemical withdrawals, and echo for structural heart disease. So this is atrial fibrillation. You see the fibrillatory waves here are irregular, multiple different amplitudes, and varying conduction. This is in contrast to atrial flutter, where there's a regular sawtooth pattern. Fibrillatory waves, the complexes are irregular, there is no frequency, and the intervals cannot be predicted. Now, note that there are other rhythms that originate from the atrium that can be irregularly irregular. So we have atrial fibrillation, of course. We have A.Fib with variable conduction. And most importantly, and this is a common mimic that's often mistaken, multifocal atrial tachycardia, as you see here, with multiple different P-wave morphologies and different rates. This is often being misrepresented as atrial fibrillation, and this one does not require anticoagulation. So the differential diagnosis, i.e. ECG mimics of A.Fib, include sinus tachycardia, atrial flutter, flutter with variable block, atrial tachycardia, multifocal atrial tachycardia, WPW, AVRT, AV reentrant tachycardia, and junctional ectopic tachycardia. The last three are commonly misdiagnosed because the P wave is not present. However, as we mentioned before, we do not make a diagnosis of atrial fibrillation simply based on the absence of P wave. There are other criteria, particularly marked irregularity. So let's look at this ECG. This is a nice challenging ECG, and it's a real case. So is this atrial fibrillation? So we have a narrow complex tachycardia. It appears to be irregular. If we look where we should normally see P waves, it appears on quick analysis that there is none. However, let's try to look a little further. I think you see here evidence of group beating, and every so often it can lead to a P wave appears. So what is your differential diagnosis? Is this sinus tachycardia with AV Wenckebach? Is it sinus rhythm with junctional bigeminy? Is it AV nodal reentrant tachycardia with 2-to-1 retrograde block? Is it non-reentrant AV nodal tachycardia with fast and slow passway Wenckebach? Or is it complete heart block? I'll give you an opportunity to go back and look at this ECG and put it within the differential diagnosis. These are our choices. So in fact, this is the same P wave creating multiple ECG QRS complexes. This is not A.Fib. So this P wave, as you see, conducts and gives you two QRS complexes. This P wave conducts and creates only one QRS complex. There is progressive prolongation, block, and then you have again P wave creating one QRS and another QRS. One P wave creating one QRS and another QRS. This is the P wave. This is not a P wave. This is a T wave, as you see here, and it indents the T wave in a specific manner. So this is called the double response or double fire. Even though it's irregular and P waves are intermittently seen, not obvious. So while atrial fibrillation represents the most common cause of irregular tachycardia, there are many other possibilities. As I said, multifocal atrial tachycardia and other SVTs with variable AV conduction, such as atrial tach or atrial flutter with variable block, can be irregularly irregular. Sinus tach with PACs or PVCs can also present as an irregular tachycardia. In this case, the patient had conduction down two separate pathways within the AV node with a very long conduction time, demonstrating a pattern known as a double ventricular response. The other prerequisite is that there are no retrograde conduction through the slow or fast AV nodal pathways, since this would result in conventional, typical, slow-fast AV NRT. So let's look at this ECG. Is this atrial fibrillation? So we see a rhythm that is not particularly fast, narrow complex, and we have intermittently a P wave, and a QRS complex that is not preceded by P wave. There seems to be some irregularity, although if you look carefully, you'll see that there is a certain periodic pattern of the rhythm. In fact, this is not atrial fibrillation. These are, again, ectopics with PR prolongation. Where are these ectopics arising from? They're coming from the junction. Again, this is highlighting the presence of dual AV node physiology. So, For the non-electrophysiologists, you'll see clearly marked here that you have two different populations of PR interval, one long and one short, which means that the patient has a fast and a slow pathway, and the presence of the ectopic blocks conduction through the fast pathway, allowing visualization of conduction through the slow pathway. What about this? Is this atrial fibrillation? It is not, because as you see here, there are negative P waves that result in this tachycardia, which terminates to give you sinus rhythm. So if you take a superficial glance at the inferior leads, you might say that it is fast, it is irregular, and there are no P waves visible. But if you look carefully, you'll see that there is an inverted P wave with a different PR interval, indicating a distance away from the sinus and the AV node. And at the time of termination, you can see clearly sinus rhythm resumes. What about this? Is this atrial fibrillation? So after tempting you with all of those complex EKGs, this is definitely atrial fibrillation. It's not typical flutter because the cycle length is very fast. And cycle length in the atrium is also quite variable. If you look in the inferior leads, again, the sawtooth pattern is not seen. So this may be regularized or more organized form of atrial fibrillation, possibly the patient on antiarrhythmic therapy. And also one of the important hallmarks of atrial fibrillation is a very wide variation of the heart rate and cycle lengths, and the average heart rate is generally quite rapid. So why do we do pulmonary vein isolation in A.Fib? Largely because the pulmonary veins are the important source of the ectopic beats initiating frequent paroxysms of A.Fib. The original seminal work from Michel Hasseguer and the group in Bordeaux showed that by ablating at the ostium of the pulmonary veins, ectopics could be suppressed and atrial fibrillation can be significantly reduced. Technology has advanced significantly at this point. We have access to cryoballoon ablation to seal the ostium of the pulmonary veins electrically, or conventional radiofrequency ablation by drawing a circle around the ostium of the pulmonary veins. Mechanisms and triggers. The most common site for pulmonary vein foci is a left atrial muscular sleeve extending into the pulmonary veins. These cells have shorter refractory periods, and therefore pulmonary vein isolation with catheter ablation isolates this region, further preventing development of A.Fib. However, as we said, A.Fib can be triggered by other arrhythmias such as AVRT, flutter, and even PACs. What about SVTs causing A.Fib? This is a very important differential diagnosis, and when you see a young person with atrial fibrillation in whom there is no structural heart disease and no left atrial enlargement, SVT needs to be considered significantly. The association of A.Fib with SVT is very well described. It can be occurring during flutter, AV nodal reentry, or AVRT during accessory pathway. Spontaneous atrial ectopy may be a trigger coming from the pathway itself. The clinical relevance is very important because ablation of the underlying arrhythmia can also eliminate A.Fib, especially in young patients in the absence of structural heart disease. Several systematic reviews from large ablation centers have shown this. This was published in the Journal of EP. 62 patients with an initial diagnosis of A.Fib who came in for procedures note that ablation of SVT and slow pathway modification was seen in a small but important number of these patients. A slightly older registry from a large medical center in Greece, again, showed that 409 patients, including the study with atrial fibrillation, at the time of initial EP study, at least 7% of these patients had SVT, leading to ablation of the SVT made the patients free of atrial fibrillation. Now, back to the ECGs. Is this atrial fibrillation? Look carefully and make a diagnosis. We have a rapid, narrow complex tachycardia, irregularly irregular, interspersed with a PVC. P wave is not seen. Yes, this is atrial fibrillation. Again, we have to consider the most common differential diagnosis, but also not to ignore the others. What about this? What about this rhythm? So in the interest of time, this is in fact multifocal atrial tachycardia. It's very rapid, it is narrow complex tachycardia, it is very irregular. However, when we look in the leads where we are most likely to see P waves, that is lead 2 and V1, you see a P wave, different morphology P wave, different morphology P wave, different morphology P wave. Variety of different P waves, clearly resulting in a QRS complex and driving a rapid tachycardia. In this case, this is a patient with severe COPD and emphysema just prior to being intubated for severe hypoxia. How about Brugada syndrome and atrial fibrillation? A.Fib is actually the most usual atrial arrhythmia in Brugada syndrome, with an incidence between 6 and 53%. The electrophysiological substrate, the channelopathy, responsible for ventricular arrhythmia, contributes to atrial arrhythmogenesis. The presence of A.Fib is actually a marker of more advanced stages in Brugada syndrome and has been related to a more vicious prognosis. Cusano demonstrated that a syncopal episode VF type 1 ECG were observed in a larger percentage of Brugada patients with A.Fib than those without. Family history of SCN5A and VF were not associated with spontaneous AF episodes. So, coming back to SVTs resulting in AFib, many case reports have resulted in association of AV nodal reentry with AFib. Untreated AV-NRT is quite common. Most of these patients receive adenosine and do not get referred to electrophysiology. Up to 4% of inducible AV-NRT among patients referred for AFib ablation. Slow pathway ablation abolishes AFib recurrences. French series, 12% of patients with AFib, less than 50 years old, had recurrence of AFib following ablation of a WPW pathway, as opposed to 55% of older patients. Ablation of additional underlying arrhythmias may not eliminate future AFib recurrence in the older patient, and therefore follow-up is required. However, in the young patients, this is a very effective strategy in treatment of atrial fibrillation. From the French registry, taking all of the reentrant tachycardias and atrial tachycardia in one group, AFib recurrence in these patients after ablation of AVRT, AV-NRT, and atrial tachycardia was statistically lower than patients who had atrial flutter ablation who also had AFib. So after adjustment for age, hypertension, and ischemic heart disease, patients with atrial flutter continued to have higher risk of AFib recurrence than patients who have SVT and atrial fibrillation. How does WPW and pre-excitation result in AFib? As you know, pre-excitation is the early activation of the ventricles due to impulses bypassing AV node through the accessory pathway. The majority of pathways allow bidirectional conduction. Retrograde conduction is seen in only 15% of cases, and antegrade only is rarely seen. Tachyarrhythmia is facilitated by a re-entry circuit using the accessory pathway termed AV reentrant tachycardia. Direct conduction from the atrium to the ventricle, seen with AFib and atrial flutter with WPW. And this is the model of re-entry as you see, down the AV node, back up the accessory pathway, although antegrade conduction can certainly occur. It is well known that AV reentrant tachycardia is the most common arrhythmia, and PAF is seen in 1/3 of patients with AVRT and WPW. It's certainly higher than the control population. There are many proposed mechanisms in patients with WPW. Since the accessory pathway has a short refractory period, rapid conduction from the atrium to the ventricle during A.Fib can result in very rapid ventricular rates up to 300 beats per minute, degenerating into VF, and high risk of sudden death. Most PAF will terminate after successful AP ablation, accessory pathway ablation, and there's a very important role of the accessory pathway in A.Fib. We generally perform APS to confirm the presence of accessory pathways. As you see here, this is the normal mechanism of pre-excitation. AV reentrant tachycardia can degenerate into atrial fibrillation. Here is a patient with WPW. This is the arrhythmia that they develop when they have orthodromic conduction. In other words, down the AV node, back up the accessory pathway. This is a narrow complex tachycardia, as you see here. So the antegrade conduction is down the AV node, retrograde up the accessory pathway. Results in a rapid narrow complex tachycardia. On the other hand, if you have antidromic conduction, where antegrade conduction comes down the accessory pathway and back up the AV node, this is in a situation where the patient has an AV reentrant tachycardia. This results in a wide complex tachycardia, which looks like VT, as you see here, because there's pre-excitation of the ventricular chambers. Very important, A.Fib and atrial flutter in patients with WPW can cause sudden death. A.Fib can occur in 20% of patients with WPW. A flutter can occur in 7% of patients with WPW due to the accessory pathway rapid conduction to the ventricles with high ventricular rates degenerating into VT or VF. The ECG features are rates over 200 beats per minute, irregular rhythm, wide complexes with abnormal ventricular depolarization through the accessory pathway. The QRS complexes change in shape and morphology. However, unlike polymorphic VT, the axis is still stable. So we'll review a case, a 32-year-old male with frequent PVCs and syncope associated with palpitations. So we see here the patient's in sinus rhythm with frequent PVCs that have a left bundle branch block morphology and prominent R waves in 1, 2, and 3. The patient has a very rapid narrow complex tachycardia that is induced by the premature ventricular contraction. During the SVT, the patient spontaneously converts to atrial fibrillation. As you see here, it's irregularly irregular. There are more atrial than ventricular signals, and the atrial morphology and cycle length is totally irregular. This is the surface ECG from the EP study, showing again irregularly irregular rhythm with a narrow complex tachycardia, consistent with A.Fib. The intracardiac recordings again confirm atrial fibrillation. Completely disorganized right and left atrial signals. This is the ablation catheter. This is the coronary sinus catheter on the left side, consistent with atrial fibrillation by atrial. This is the induction of the atrial fibrillation. Here you see here a single P wave and then atrial fibrillation occurs again. During ventricular pacing, narrow complex tachycardia is initiated. You see here, this is the V pacing, narrow complex tachycardia. And during mapping, the intracardiac electrogram shows a narrow complex tachycardia with a short RP tachycardia. This is the QRS. This is the retrograde P wave. It's within 30 milliseconds of the QRS. Again, demonstrating a short RP tachycardia. Couple of beats of sinus rhythm, and then atrial fibrillation is induced. So in fact, in the same patient, 2 ablations were done. First of all, the patient had a slow pathway. So ablation of the slow pathway was performed in the classic location of the slow pathway. And you see here, this is the electroanatomical map showing the right ventricular outflow tract, right ventricle, tricuspid annulus. Here's the AV node, and here is the slow pathway. After ablation of the slow pathway and the AV nodal reentry, attention was then turned to the PVCs, and the PVC focus in the right ventricular outflow tract, the septal wall of the RVOT, was successfully ablated. Post-ablation, the patient had no further PVCs. Pre-ablation, he had 23,000 PVCs, 23% PVCs, no further palpitations or syncope, no A.Fib on the Holter, no SVT. So the conclusion of this case, frequent RVOT PVCs inducing very rapid SVT, AV nodal reentry, degenerating into PAF in a patient with a normal heart. Ablation of the slow pathway and the PVC eliminated both the A.Fib and the SVT and relieved the syncope. Here's another case. This is a 43-year-old oil field engineer with palpitations and pre-syncope. As you see here, the patient has manifest pre-excitation with a delta wave, a short PR interval, a delta wave that is positive in V2, V3, V4, and V6, and positive in 2, 3, and AVF. The patient was noted on the surface ECG to have pre-excited atrial fibrillation up to 300 beats per minute, consistent with a very high-risk accessory pathway. The location of the His bundle is marked using the His bundle catheter. Coronary sinus catheter is placed, as well as the His bundle catheter and the RV catheter, right atrial catheter. In this case, the patient had a parahissian accessory pathway, very high risk accessory pathway, in which we note that the actual pathway here, marked in white, is immediately adjacent to the bundle of His, marked here in yellow. And of course, there's a very high risk of AV block. So in this situation, we utilize electroanatomical mapping system and cryoablation. So cryoablation allows you to freeze. We do a test freeze to identify that we are not ablating at the bundle of His. And as you see here, with cryoablation, there's disappearance of the delta wave without AV block and a normal PR interval, almost immediately, as you see here. So parahissian accessory pathway, a very high risk of sudden death due to pre-excited A.Fib. So this is sort of a close-up view to show you. So the parahissian accessory pathway is in fact sitting directly on top of the AV node, as you see here. And here is the delta wave, as you see. Post-ablation, narrow QRS with no delta wave and normal PR interval. So here's another patient. This is a patient with a narrow complex supraventricular tachycardia, very rapid, rates over 220 beats per minute, that terminates with adenosine. So here you see the electroanatomical map. The patient has clear retrograde conduction through the accessory pathway. The accessory pathway is located here at the 6 o'clock position on the tricuspid annulus. Here's the AV node. So the conduction proceeds retrogradely. After successful ablation, you'll see now that conduction proceeds in the normal direction through the AV node after ablation of the accessory pathway, instead of going retrogradely through the accessory pathway. So with that, I will stop. I'm sure there's many questions for discussion. And thank you for your attention.
Dr. Hani, first of all, let me congratulate you and thank you for this presentation. Highly intellectual stuff, highly recommended for general cardiology residents and as well as for the electrophysiology trainees as well. Uh, you have raised the standards of our session today. So thank you so much for this perfect talk. I'm very much impressed. Dr. Hani, I'm going to ask you a few questions and I will request you to give us very rapid answers.
Sure.
My first question will be what you recommend about the anticoagulation protocol after you do the A.Fib ablation?
Yes. So after A.Fib ablation, it's really critical to have a very intense anticoagulation. There's a lot of lesions, whether you do cryo or RF. So usually we do our A.Fib ablations on full anticoagulation. We do not interrupt anticoagulation. We continue throughout. During the procedure, we also monitor the ACT and we keep the ACT up to 350. Post ablation, we tell the patients that they need to maintain their NOAC or warfarin precisely. We don't let them go home unless they are fully anticoagulated. And we tell them there is no possibility to eliminate anticoagulation long term unless their CHA2DS2-VASc is 0 and only after 6 months of monitoring.
Great. And another question is, what about the recurrence rate after you do the PVI, cryo balloon ablation for A.Fib?
So it depends on
Your personal experience.
Yeah, so we are very selective cryoballoon ablation. We actually do a CT angiogram to look at the pulmonary veins prior to the procedure. If there are anatomical constraints, we will do RF. If the patient has a dilated common ostium on the left side, again, RF is more appropriate. But we have a large experience with cryo. Again, international experience is similar to ours. It's about 15% recurrence with cryo, and for paroxysmal A.Fib as well. Most common cause of recurrence is untreated sleep apnea. Untreated sleep apnea, we try to focus on that before sending the patient to ablation.
Okay, great. And the third question, which will be the last question as we move towards our second presenter. How many percent of AVNRD or AVRT represent as A.Fib for the first time, for the first presentation?
Yes.
And
So
can you share any data?
yeah, so actually I didn't have time to go through all of the statistics due to the length of the procedure. But in fact, if you look about somewhere between 17% of patients, young patients, this is the clue, right? Young patient, no structural heart disease, paroxysmal A.Fib after an episode of prolonged palpitation, probably have underlying SVT. So when we have a patient with this profile, we don't directly go to RF and we don't directly go to cryo. We do an EP study at the beginning. And we try to induce. And in fact, we have seen, at least in this year or so, at least a handful of patients who have this. So you have to spare them the A.Fib ablation.
Great, great. Thank you so much. I will request Dr. Emin if he can introduce our next speaker.
It's my honor to present our next speaker, Dr. Constantini. He will talk about ECG findings of Brugada, right?
Yeah, we will take a walk from the ECG to the EP lab with the Brugada syndrome patient. During the presentation, we're gonna know what's exactly in the kind of patient that we are gonna take to the EP lab. So stay live.
Great, great. So it's over to you, Dr. Lorenzo.
Hello everybody, this is Lorenzo Constantini from Italy. I'm here to share with you a 20-minute trip from ECG to the EP lab, talking about Brugada syndrome. You might be wondering why we have to talk about that. Well, I'm sure that if you don't know yet the end of the story, you're gonna be surprised. During my training, I spent a couple of years in Barcelona, and I had the privilege to enjoy a lot of talks like this by my mentor, Joseph Brugada. These talks used to share with me a lot of stories, free tips and tricks about Barcelona Football Club, Brugada syndrome, and electrophysiology in general. In this lecture, I would like to share a few of these concepts with you. Thank you so much for inviting me here. It's a pleasure. Current guidelines for the management of patients with ventricular arrhythmias and the prevention of sudden cardiac death define this entity as an inherited primary arrhythmia syndrome. The diagnosis of Brugada syndrome is based on a typical ECG pattern occurring either spontaneously or after provocative drug tests with intravenous administration of sodium channel blockers. The presence of all other known causes of ST segment elevation in right precordial leads, known as phenocopies, should be excluded before making the diagnosis of Brugada syndrome. Age and sex-related penetrance, incomplete penetrance, and variable expressivity are all hallmarks of this cardiac entity. Nowadays, it's difficult to discern the true burden of Brugada syndrome due to the unknown real prevalence of asymptomatic patients and the dynamic variability of ECG pattern. Nonetheless, the prevalence of Brugada syndrome is believed to range from 1 in 5,000 to 1 in 2,000 individuals. The incidence of Brugada syndrome pattern on ECG has ranged from 0.12% to 0.8% in several studies. It has been considered responsible from 4 to 12% of all sudden deaths and up to 20% of sudden deaths in patients with structurally normal hearts, and is 8 to 10 times more prevalent in men than in women. Following the original description of Brugada syndrome, there was much confusion about its ECG characteristic and diagnostic criteria. To clarify these ambiguities, an expert consensus document was published in 2012, establishing 2 descriptive ECG abnormalities for Brugada syndrome. The type 1, the code type, the one we are seeing in the slide, is the only diagnostic pattern for Brugada syndrome. It is characterized by an ST segment elevation of 2 millimeters or more in one or more right precordial lead. The descending ST segment crosses the isoelectric line, and this is generally followed by a negative and symmetric T wave. The Saddleback type, type 2, is only suggestive of Brugada syndrome. It is characterized by an ST segment elevation of 0.5 millimeters or more in one or more right precordial lead, followed by a convex ST. Their first wave may or may not overlap the J point, but it has a slow downward slope. The ST segment is followed by a positive T wave in V2 and is of variable morphology in V1. To facilitate the differentiation of type 2 ECGs highly indicative of Brugada syndrome from other Brugada-like patterns such as athletes, pectus excavatum, and arrhythmogenic cardiomyopathy, several additional criteria have been suggested. One of these criteria uses the triangle formed by the ascending and the descending branch of our first wave. Frequent variation in the ECG patterns can occur within a single patient, including the absence of classic ECG pattern on a given day, defining the concept of concealed Brugada syndrome. And here we have the mystery of Brugada. I would like to say you something more about Brugada ECG. This ECG is from a patient that was referred to us for a syncope during recovering from sport. It smells. Well, it seems to be an incomplete right bundle branch block, but if you focus on QRS duration in the peripheral leads, you can see that QRS is very narrow. Well, I'm sure you all already know the end of the story. Talking about dynamic ECG pattern, 12 leads alter ECG can be a powerful tool in detecting a dynamic type 1 ECG. In our group, if there's the suspicion of Brugada syndrome, before making any other test, we perform an alter ECG, placing all 6 precordial leads of the alter in V1 and V2 position, in the second, third, and fourth intercostal space, respectively, in order to optimize the sensitivity of the technique, increasing the probability to sample a spontaneous type 1 ECG. The next step is the sodium channel blocking test. When there's a clinical suspicion of the disease without a spontaneous type 1 ECG pattern, for instance, as a subject presenting with syncope, agonal respiration, aborted sudden death, or only a family history of Brugada syndrome, or a suggestive but not diagnostic ECG, a pharmacological test with a sodium channel blocking agent shall be performed to unmask the disease. The test must be performed under continuous ECG monitoring, and it is considered positive when a type 1 ECG pattern is identified during the infusion. Widening of the QRS to more than 130% over the baseline value of the presence of frequent ventricular premature beats or more complex ventricular arrhythmias should be a warning sign to stop administration. Intravenous agmalin and flecainide are the most widely used pharmacological tests. In some countries, there are no class first intravenous antiarrhythmic drugs available, and oral doses of flecainide or propafenone are used instead. Continuous monitoring should be maintained until the ECG reverts to the baseline, and it is important to remark that, like all the tests we perform, nearly 25% of drug-induced tests might be false negative, and this should be taken into consideration when, for instance, a patient experiencing aborted sudden cardiac death with a suspect ECG as a negative flecainide test. Flecainide test has a failure rate more important than agmalin test. Agmalin test is more sensitive by our center experience. A repeated drug test using agmalin should be considered so whenever possible. Structurally normal heart, who knows? Although Brugada syndrome is commonly considered as a channelopathy, evidence has revealed structural derangement of the right ventricle. Using cardiac MRI, Brugada syndrome patients were found to have right ventricular motion abnormalities compared with normal individuals. Although late gadolinium enhancement was not detected in cardiac MRI, histological evidence of substantial fibrosis in the ERV of T epicardium corresponding to a low expression of connexin 43 was found in the hearts of Brugada syndrome individuals. Of course, malfunction of ionic channels still play a key role in the current view of pathophysiology of Brugada syndrome, but a broader vision nowadays is mandatory because often ionic channels and connexin play together to keep the normal function of the cardiac cells, but this is another story. Let's talk about increased sudden cardiac death risk. That's the heart of Brugada syndrome. There are two major pathophysiologic models explaining the electric abnormality in Brugada syndrome, namely the repolarization and the depolarization models. Despite their differences, both models agree that the major region of pathology is right ventricular outflow tract. In both the pathophysiological models, transmural or intercellular heterogeneity or membrane potential create in a given moment of cardiac action potential an electric gradient that can trigger functional reentry. In the same way, heterogeneity in impedance, conduction, or presence of fibrosis can contribute to worsen the situation and to harm the electrical bone. Let's talk about sudden cardiac death stratification of risk. Accurate stratification of risk of sudden cardiac death is a major challenge in the clinical management of Brugada syndrome patients. Subjects presenting a drug-induced Brugada ECG and completely free of symptoms can be classified as low-risk patients. Subjects showing a fever-induced type 1 ECG without any symptom can be classified as intermediate risk patient. Subjects showing a spontaneous type 1 ECG or aborted sudden cardiac death or syncopal events or EPS inducibility maybe can be classified as high-risk patients. And the management is very different from one group to the other one. In low-risk patient, no clear-cut recommendation have been defined, and low-risk patients are substantially asymptomatic patients with drug-induced pattern. Ambiguity surrounding the severity of the disease in this group and the value of electrophysiological study inducibility identifying high-risk patients exacerbate the difficulty in management of the asymptomatic patients. The reported annual rate of asymptomatic Brugada syndrome events has decreased over time. This change probably reflects an inherent early referral bias when particularly severe forms of the disease were more likely to be diagnosed. Even among more recent studies, the rate of arrhythmic events in asymptomatic Brugada syndrome patients is not negligible, 0.5 to 1.2 annual incidence, so the risk is still present. Appropriate assessment to rule out purely vasovagal or neuromediate syncope is also recommended in subjects that have no clear events, because the management between asymptomatic patients and symptomatic patients change a lot. Women with Brugada syndrome typically show more benign clinical features with a lower percentage of type 1 Brugada syndrome ECG and a lower prevalence of symptoms. However, events still occur in women and no appropriate sex-specific risk predictor exists. Let's talk about the intermediate risk group. An important risk factor is a fever-induced type 1 ECG, because this feature reflects a temperature-induced impairment of cellular electrophysiology. ECG of Brugada syndrome, the type 1 ECG reflects an impairment of cellular electrophysiology. Never forget this. This is the heart of Brugada syndrome. And this potentially lead to electrical instability and ventricular arrhythmias. Therefore, a more strict clinical follow-up and eventually, I recommend this, ILR implantation are desirable in this group of patients. In addition, I always instruct my patient to take paracetamol in case of fever, and if unable to achieve a temperature of less than 37.5 degrees Celsius, I recommend them to go to the emergency department for monitoring. That's the key point. Emergency department for monitoring with fever in patients with the type 1 ECG induced by fever, because you never know the magnitude of electrical instability and the magnitude or impairment of cellular electrophysiology in this class of patients. It's very, very important. About high-risk patients, that are patients showing a spontaneous type 1 ECG, and for my group, spontaneous type 1 ECG if asymptomatic with the EPS inducibility, or patient who experienced an aborted sudden cardiac death, or patient that with the spontaneous type 1 ECG or induced type 1 ECG and syncope. So symptomatic patient go to ICD implantation. They have to be protected. So ICG implantation, strict clinical follow-up, and avoid fever and Brugada drugs. Syncope is an indisputable risk factor and recognized by all studies And most of them agree that the presence of syncope in combination with a spontaneous type 1 ECG pattern is a robust marker of poor prognosis during follow-up. Controversial evidence suggests the symptomatic patient and more easily induce arrhythmias during an electrophysiological studies, but this is still controversial. The expert consensus document and the current guidelines for prevention of sudden death neither encourage nor discourage electrophysiological study for Brugada syndrome risk stratification, but simply state that an implantable cardioverter defibrillator may be considered in cases of inducible ventricular arrhythmias. Barcelona Group has traditionally used EPS for the risk stratification in asymptomatic patient with a spontaneous Brugada syndrome type 1 ECG, as I said before, and this is supported by several large perspective registries. Also, a ventricular refractory period of less than 200 milliseconds has also been proposed as a predictor of adverse events in Brugada syndrome. And now let's talk about the worst category, the patients that are symptomatic, plant an ICD, you avoid fever, you avoid Brugada drugs, you follow up them very strictly, and they still have events. Multiple ICD shocks, arrhythmic storm, with the very, very difficult end patient. We are still two options for this patient, quinidine and ablation. Okay, radiofrequency ablation has risen as a promising therapeutic option for Brugada syndrome in the past decade. Studies have demonstrated that in addition to abnormally low voltage, prolonged duration, and fractionated electrograms, histologic and molecular changes, including inflammation, fibrosis, and low expression of connexin 43, have also been found at the anterior right ventricular outflow tract epicardium. These findings have established the foundation of ablating the substrate as a feasible treatment for the Brugada syndrome. The current consensus recommendation considers radiofrequency ablation as a reasonable therapy for Brugada syndrome patients with arrhythmic storm or repeated and appropriate ICD shocks, because we have to remember when a Brugada patient has an ICD shock, we have to check if the shock is appropriate or not, because the Brugada pattern can jam the ICD itself. Just remember, and this is another story, but is subcutaneous ICD in Brugada patient do it better. With the progress made in recent years, there is hope the radiofrequency ablation might even offer a cure for these selected patients with a very severe form of Brugada syndrome, a cure for the most severe disease. Despite early attempts for ablation, beginning with the endocardial approaches, endocardial ablation of arrhythmogenic PVC and endocardial mapping with ablation of late activation zone, later studies have shown that most of the electrophysiological substrates locate at the right ventricular outflow tract epicardium. And thus, epicardial ablation has become a more accepted approach due to its improved efficacy in eliminating the arrhythmogenic substrates. So, the procedure is complex. You have to select the patient candidates to this kind of procedure. And the target of the procedure is ambitious. ECG normalization and not arrhythmia reinducibility. It's very hard target for this kind of the procedure. Not only ablating PVC, you have most of the times you have to ablate the entire surface of RVOT. So selecting patients for this procedure is very important because the procedure itself is an hard procedure to perform with high rate of complications. Here you see the mapping with sodium channel blocked administration. When the sodium channel blockers are administered during mapping, this increases the resolution of the identification of arrhythmogenic substrate and consequently the efficacy of the procedure itself. Substrate ablation is associated with the ECG normalization, but you have to identify the substrate before, and you have to ablate it anteriorly. You have not to leave 1 gram of arrhythmogenic substrate, otherwise you won't reach the goal of the procedure. This observed correlation further suggests that improving the sensitivity of substrate identification is the key to improve ablation efficacy. So, 3-step procedures: identification of the substrate without sodium channel blocker, enhanced identification of the substrate with sodium channel blocker, and then ablation. Ablation of all the substrate. That's the key. And contextually, ECG check the normalization of the type 1 ECG pattern. So take home message. There's quite a long way between ECG and EPLAB in Brugada syndrome. The complexity of Brugada syndrome continues to evolve. It's very fascinating disease. And therefore, understanding the mechanism of this disease is imperative to provide better alternatives for treatment. Early detection and risk stratification are areas of major importance in the treatment of Brugada syndrome. And radiofrequency ablation of RVOT substrate has risen as a promising treatment modality for Brugada syndrome in selective, very high-risk patients, although larger scale and long-term follow-up studies are required to further determine its merit, okay? So, what's the take-home message? The same of the last year, the best is yet to come. And I hope that the best is coming soon and all the pandemic ends, and we can be all together again as last year, because memories are very important, and I appreciate a lot the memory I used to share with you, and I miss you a lot. Thank you very much for your attention, for inviting me, and for this 20 minutes walk through Brugada syndrome. Thank you.
Dr. Lorenzo, I can imagine about the hard work that you have put in preparing this presentation. This is an amazing job. I can truly understand it. You have really touched all aspects of Brugada, from ECG to the EP lab. Amazing. And although all the slides were important and I like them, but the slide which was related to the certain cardiac death risk stratification, that was very nice, because it is clinically very important. So thank you so much and congratulations.
Thank you, Haseeb. Thank you. It's a pleasure to meet.
I have a quick question. Thank you, thank you. I have a quick question for you. What is the difference between Brugada syndrome and Brugada phenocopy?
Well,
quick answer.
Yeah, it depends, because if you go to the emergency department and you see a patient with chest pain and you see a Brugada electrogram, you have to discard first if this patient have maybe a pulmonary embolism that can be on the ECG a phenocopy of Brugada syndrome.
Great. So we need to consider things about the drugs and the other things which can look alike the Brugada syndrome.
Yeah, we have to be clinician at first and then electrophysiology. We don't have to think when we see an ECG, we have to put together all our sensibility of clinician to put the information together and to really understand what's the problem of the patient, I think. Because if we stop to the Brugada pattern on the ECG, we are just able to recognize the pattern, but we have to be more smarter than just detect the pattern. That's why we have to discard all the phenocopies that can be the real diagnosis instead. A pulmonary embolism is one of the worst phenocopy on the ECG of Brugada syndrome.
I agree. Thank you so much, Dr. Lorenzo. And Dr. Emin, before, we are moving towards the end, so if you would like to say something about this session or the speakers, please go ahead. Then I will conclude the session. You are muted.
Nothing much actually. And they already summarized and emphasized very important points, and we are almost finished. So I would like to congratulate all of our speakers.
Okay. So it is time to close the session. I would really like to thank Dr. Hani Sabbour and Dr. Lorenzo for giving us their precious time and share their knowledge with our audience. And I would also like to thank my colleague, my friend, Dr. Emin, for being with us. So with this, I would again thanks all the speakers, my co-chairperson, and especially the audience who has been with us till now. Have a good day.
Have a good day. See you. Thank you.